First, the acute hospitals. For inpatient admissions to acute hospitals, we currently use individual income as the basis for mean testing. I have seen in my clinical practice and also meet people during my Meet the People sessions how a sole breadwinner may earn a high individual income, but shoulders the full responsibility for his or her household needs alone. For such individuals, healthcare costs can become a significant strain, and I have great sympathy for them. MOH will thus align means testing for inpatient admissions to acute hospitals from individual income to PCHI. With better means testing through PCHI, there is therefore less need to rely on ward choice. Therefore, we will unify B2 and C subsidies into a common framework, maintaining the same minimum and maximum range at 50 to 80%. This acute inpatient subsidy framework will also be applied to day surgeries, which are currently subsidized at 65%. Effectively, this will increase subsidies for 70% of day surgery bills and encourage day surgeries instead of inpatient admissions when appropriate. Let me go to the SOC setting. To bring about greater progressivity and allow resources to be better directed, MOH will introduce 2 new subsidy tiers in the SOC setting for patients with higher PCHI. 40% for PCHI more than $3,300 and 30% for PCHI more than $6,500. Now, with better targeted subsidies at the SOCs, we will now allow private patients in the inpatient setting to opt for either subsidized or private SOC for their discharge follow-up. This brings me to community hospitals. Having worked in an acute surgical ward, I have occasionally encountered patients who have recovered significantly to be well enough for discharge to a community hospital for subacute or rehabilitative care, but who are reluctant to do so due to the differences in the subsidy levels between acute and community hospitals. We will therefore enhance subsidies available in our community hospitals to support patients in utilizing appropriate care and facilitate the smooth flow of patients from acute hospitals to community hospitals. This allows acute hospital resources to be available for patients who require more intensive acute care. We will raise the maximum subsidy of community hospitals to 80%, aligned with that of acute inpatient care, and further increase the minimum subsidy from 20% to 30%.